Image-guided surgery essentially is part of the computer-assisted surgery, and in fact in ophthalmology many a time we use microscope to work inside the eye, but my specialty mainly rests on outside the eyeball itself, involving the lacrimal system where the tear drains are, the orbital surgery which involves the structure outside the eyeball, the eye muscle, the eye bones as well. So many a time we cannot actually see clearly where we are because we are outside of the eyeball. So pretty much like other part of the surgery around the head and neck region, we rely heavily on the preoperative images of the patients. And pretty much like driving, a GPS system would be very nice to guide our direction. And similarly, if we are operating inside the orbital system, an image-guided system will be very, very helpful. There are a lot of development in the image-guided surgery, not only in ophthalmology but elsewhere inside the body, for example in neurosurgery and spine surgery. In fact, there are different types of navigation system we can use. There are an optical system which use infrared, and there are electromagnetic systems that use different types of physics. The optical system has a very easy concept. There is a system that has a camera head that looks at the patients, and then you have integration of the preoperative images, and you put in a fiducial marker, which is a three-dimensional reference frame nearby the patients, and then the system can recognize the frame, integrate the preoperative system, and then you register the patient so that the system knows exactly in a three-dimensional sense where and what the patients constitute compared to the preoperative images. But of course, there are limitations for the infrared system. When there are operative staff, like your nurses, your assistant, blocking the camera, then the infrared system doesn't work. So there is another system called electromagnetic system, in which there is a coil that you put directly underneath the patient's head, and that generates an electromagnetic field that helps to do the job of the infrared system. But of course, the electromagnetic field again has this limitation, because inside the operating field, you're going to use a lot of metallic instruments, steel instrument, and those instruments are ferromagnetic and may cause interference of your electromagnetic field. So nowadays people are trying to go for a hybrid system, meaning both the infrared as well as the electromagnetic system are used together to help with the registration. Then surgeon has again go back to the basic. The anatomical knowledge and the preoperative assessment of the patient will be crucial. Pretty much like when you're driving in the countryside without access to a GPS, then you have to use your basic knowledge and recognize the landmark. I think there are limitations, as you mentioned earlier on. If the system where you work doesn't allow you to have all the top-notch or state-of-the-art technology, I think we just have to go back to the basic and rely on the anatomy. But of course, technology itself cannot replace clinical judgment. Even if you have the best technology, if you don't have the skills, if you do not have the good clinical judgment during the surgery, then you can make bad decision. And even if you have the best technology, bad decision will have poor outcome. That has a couple of references. The first thing, as physician or surgeon, the first thing is a clinical outcome. Patient has to get well, you have to achieve the surgical goal preoperatively, and you should have good clinical outcome. The second thing is efficiency. How much time are you spending on that cases? How much money and how much OR resources are you spending? The third is research potential. Do you have any room for further improvement? In Hong Kong, we are practicing Western medicine, and as an ophthalmologist, we are trained in the Western fashion, and I have a personal history of working here in the United States during my fellowship training. So we have a lot of integration of so-called Western medicine, but I think the key point is, regardless of where you are, I think technology itself is driving the field up. And I think one of the limitations in working in the United States is the authority. For example, the FDA has a lot of limitation, and many a time they are not actually at the top notch in terms of development. I think anything that is imaginable is something that is achievable. Well, to be in a more realistic term, we want to look at what is our main obstacles or problem to achieve good outcomes. So we work our way around this. So it's a problem-driven type of direction.